Good morning to everyone, uh, or good afternoon, or good evening, wherever you are. This is a small account to address a very big problem in the low and medium income countries, or what we call the developing countries of the world. I am actually a professor of psychiatry at University Tunku Abdul Rahman in Malaysia, named after our first Prime Minister. The logo of this university is here. You can see that. And I have been teaching psychiatry for almost 50 years. But in another university, in University of Malaya before, and then in various other universities, including several universities overseas. And during this period, especially in the last 20 years or so, I have worked in many developing countries or low and medium income countries. And even during my time when I first started working in psychiatry, as a psychiatrist, I qualified in 1973. I was very distressed by the practice of psychiatry, the services available for psychiatry, and the way psychiatric patients are treated and managed in many developing countries. I did my first training in Malaysia in a university hospital, which was quite new. And we did not have locked wards. We did not have barbed wire and all that. But when I went to work in other parts of the country, as well as other parts of the world, I was shocked that the low and medium income countries have got a very bad record of how they treat the mentally ill. And because of that, there's also a huge stigma against anything to do with mental illness and mental patients. The discrimination to the poor. People talk about mentally ill never recovering because they're always dangerous and violent and will never recover. The reason for this is a bit complex, but quite easy to understand, because when we look at the way the mental patients are treated in locked wards, it is not just locked ward, but with so much security and so little care for the patient, that any right-thinking person will have to conclude that mental is dangerous. In reality, of all the mental illnesses, the 450 mental diseases in the International Classification of Diseases of the WHO, only 7% have got to do with dangerousness, violence, and psychosis. The rest are mostly anxiety and depression, some substance abuse, and some child psychiatric disorders. So why are we focusing on 7% as our mainstay of psychiatric care and treatment, but also psychiatric teaching? Generations of medical students and nurses and healthcare workers have the impression that psychiatry is a dangerous subject. It should be in prisons, not outside. So this set of slides is to try to impress upon you that we need to bring about change, and how that change can be brought about in changing attitudes and practice of psychiatry, and bring about reform in the low and medium income countries. Why change mental health and psychiatry at all? You have to be blind not to see the disparity between psychiatry, mental illness, and physical health, medicine, and all other clinical disciplines, and the way those are delivered. Some people, again and again, and this goes on even to today, have often asked in their campaign to try to integrate psychiatry into medicine. or mental health into physical health. They say mental illness is like any other illness. Is that really true? At least the way it's practiced. If it's like any other illness, it should be treated like any other illness. But the practice in low and medium income countries definitely is very different. Now this is some pictures from a country I visited, 2 countries I visited during my work. And the outside of the general hospital on the left is like this, like any other hospital. There's no barbed wire, there's no fence. You go inside, it's like this, in the medical ward. Beautiful medical ward. It's a new hospital. It's relatively new. It's clean and beautiful, no lock, no doors. Now, one corner of this building is a small room where the door is broken. It's dirty. There's no beds. There's no locker. Luckily, when I went there, there's no patient. This is another country where I went. They needed a place to lock up the mental patients. So a doctor actually donated a cell with 2 grills like this, exactly like what you see in a prison. Why is this so? What's the reason for this disparity? Like this and like this and like this. When you say mental illness like any other illness, we're not being honest. We're not being honest. This disparity, even up to the 21st century, was achieved by long held back by lack of science of stress, behavior, and other gross differences in medical progress and teaching. Revolutions only occurred in psychiatry with the first real treatments for abnormal behavior in 1954. But entrenched attitudes still hold sway some 60 odd years later, with obsessional importance of the 7% of all mental illnesses. In other words, it's almost as if psychiatry means psychosis and nothing else. What about the anxiety and depression? Well, you don't see them in the mental hospital. Where are they? They're somewhere outside. And they're suffering anxiety, depression, suicides, attempted suicides, parasuicides, accidents, alcoholism, substance-induced trauma to the brain, to the mind. Oh, that's not so important. What's more important is psychosis. You go to many low and medium income countries, the students and nurses are taught, medical students and nurses are taught, that all psychiatry is in the psychiatric ward or the psychiatric hospital, which is worse, where large numbers of mentally ill, psychotic, severely ill, highly suicidal are admitted. So severe psychosis is being emphasized at the expense of 65%, the 7% of severe psychosis, so 65% of stress-related illness. We still know little about stress, although gradually the word stress, anxiety and depression, in its commonest form, forms well over 60% of primary healthcare related psychiatric illnesses. And these are figures from, there are many, many figures like this from different sources. This one from the internet that I saw recently. And this shows that depression, if you can look on the left, the disorder here is depression, 264 million, anxiety disorder, 284 million, bipolar disorders, only 46 million, eating disorders, 16 million, schizophrenia, 20 million, any mental or substance abuse disorders, total is 970 million. Alcohol use alone is more than bipolar disorders. Drug use disorders is 71 million, more than bipolar disorder, and by far more than the schizophrenia. So we have to climb mountains and elephants of prejudice to tame that concept, that misconception mountains of ignorance in highest medical and healthcare systems. It's legendary. I have been to so many places where the highest authorities in healthcare did not know what psychiatry is, full stop. They thought it's all madness, all madness. Legacy of cells, locked wards, even doctors are donating a cell. Security conscious administration takes precedence over stress, anxiety, depression, related to family problems, money problems, job problems, crisis problems, COVID problems, and so on. Huge effort is needed. And this has actually affected doctors, psychiatrists, and the public. So everybody believes that psychiatry is psychosis. That's it. What about the rest? Huge effort is needed for a massive paradigm shift. Shift from our original wrong concepts. May not be many passionate young doctors willing to rock the boat of comfort and say, I don't want to change all this. I mean, it's going on for years and the system is like that. Ministry has only built the locked wards, so let me just keep it and work there, get my salary and risk the wrath of retaliation. You need some people who are willing to think out of the box. Non-communicable diseases have recently become very important because they find that communicable diseases like infections, malaria, and so on are being controlled quite effectively with medicine, still going on, tuberculosis and so on, but still relatively well controlled. Although excessive smoking, alcohol consumption, and lack of exercise are associated with NCD and the related problems, is surprisingly yet to be explored and used in primary care settings. Lifestyle diseases have caught on to medical terminology. So everybody's saying lifestyle disease, lifestyle disease. Primary healthcare related psychiatric illnesses are not often taught or managed. In fact, if you go to most developing countries, the primary healthcare clinics, there are many of them. One thing I must say is that primary healthcare services, even in the poorest countries I've been to, poorest countries, some of them are poorest in the world, they have a very good primary healthcare service. Admittedly, not very sophisticated, but it's very, very available, even in the remotest areas. But when you go to primary care setting, you see patients like this by the thousands. This is a clinic in Malaysia, which sees 1,600 primary care patients. The number of psychiatric problems, emotional problems, stress-related problems would easily be 300 per day. There is no psychiatric service whatsoever. And the primary care doctors are not trained to detect stress-related problems in patients. They only know if a patient is psychotic, then they know. Then quickly they'll send him to the nearest psychiatric clinic, which is 4 or 5 kilometers away. So as far as they're concerned, 1,600 patients all physically ill. There's no mental problem. So with some difficulty, I started a stress management clinic. And they were very supportive. In fact, many of them recognize that there are some stress problems. They don't know what it is about, what causes it, and so on. So they provided me a lot of support. I'm eternally grateful for them, especially the director of the clinic and his staff and his nurses. Wonderful. They gave me a chance to start a clinic in one of the only room that is available. So we have to bring on refocus, recognition of mental health gap and mismatch. And we need to, whether it is in a center or in a country, we must look for that passion to change wrongs of focusing too much on the psychosis and less on the stress-related problem, which is far larger in number and contributes in many ways to NCD, which everybody is trying to control, but not the emotional content of the management. Catalytic experience needed over and above the recognition that there are these problems, because we need a person who can see that stress-related problems and link it with the primary care setting. To jointly organize with the primary care workers, the consultant should organize some kind of change. Official support at national level, regional and world level by NGOs or governments body is required. So what we need is, first of all, recognition. Yeah, there is a problem. Many places don't even recognize that. Psychiatry means psychosis. That's it, finished, nothing more. We need to go into the wider area of primary care psychiatry or stress management psychiatry. Then you must have a passion for change. So stop. We need to change this. That passion is not easy to get. So bringing about change means somebody's got to be the passionate person to change it. Catalytic experience will be brought about when a psychiatrist comes and says, this is how to do it. I'll show you how to do it. I've done it before. It works relatively cheap. Money is a big problem. In any change, when you mention money, oh, you have to wait for the budget and wait, nothing happens. Official recognition of this change is important. Why? Because if you walk in with some clinic and say, look, I want to do this, and they say, yeah, good idea, but we have to get permission from the headquarters and permission from that and permission from this, right up to WHO. It never works. So you need to refocus by having recognition. Number two, a passion for change. Number three, a person willing to help, an expert. And recognition by the organization that will back it up. Why past efforts have not succeeded in LAMICs to change this to primary care focus? Trained locals have left or not returned from high-income countries. In poor countries, they don't have many training programs, so they go overseas for training and then they don't come back. This brain drain we have all known for many, many years, and not changed very much. They were trained in different settings with very good infrastructure in developed countries, on high-income countries, and prefer to work there for their own sake, for their families and their future, so they just abandoned the countries of origin, the low-income countries that they came from. Few who returned were not enthused with passion to change. They've come back and say, what can I do? I just carry on. No, I don't want to change all this. Very complicated. Patients are dangerous. We cannot open up the wards. We cannot have all these things. In many Islamic countries, local training, career structure has started. Actually, they've started low-income countries. You know that, you may not know this, Cambodia, which went through a terrible traumatic civil war with killing fields and all that, actually started retraining, or rather training for the first time psychiatrists in their own country in 1995, 95 and 96. Long time ago. It's more than 20 years ago they started. And today they have about 50 psychiatrists trained. In a country like Cambodia, you have to go there to know what they went through. You know, killing fields, millions were killed. So even poor countries have managed to do that. So there are people with interest and backing from the organizations. In that case, they were backed by University of Oslo and the International Organization for Migration. And some psychiatrists from the Southeast Asian region, from Singapore, from Malaysia, from Philippines, Thailand, actually pitched in to help in the training. And we are eternally grateful that these people who came to help, the Norwegian sent Professor Edward Hauff from Oslo University to coordinate the program, and we managed to get it moving. In many Islamic countries, local training, career structure, local governance, once they have psychiatrists, it's not conducive to change. They may produce blockers. Yeah? Some people, they produce the psychiatrists either by themselves or from overseas. When they come back, first thing they do, they don't want to change anything. What I call blockers to change. Or like ostriches bury their head in the sand, refusing change. You have to work in some of these countries to see and believe the kind of things that block change. Maybe need for critical mass of change makers. And that's a very big problem, because many of these countries, low-income countries, very few psychiatrists. The numbers of psychiatrists in many of the developing countries is between 1 and 2. There's a country in the Asia Pacific region which has got a population of 1.6 million and only one local psychiatrist. They managed to get a psychiatrist from another country on contract, but he'll be going back soon. So there's only one psychiatrist, and it's only in the capital city. Once you go 60 kilometers outside, there's nothing. They produce some psychiatric nurses, but their training and their ability to manage the patients is very limited. So you need to also have small numbers, not likely to bring about change, whereas bigger numbers will have the critical mass to bring about change. Need to reduce brain drain, train locally, and more commitment to changing psychiatry. Enlighten leadership for change, not many. Many in positions of power are thrust into positions not always the best for leadership roles. As I said, sometimes you have a situation where somebody takes over the leadership. I've seen this in many countries. Sometimes the person is not even a doctor, not even a healthcare worker at a higher level. It's just in one case, was a health extension worker. He was made the head of psychiatric hospital. Well, these are some of the realities. I mean, it's all very well to say, no, we need a psychiatrist, but they don't have a psychiatrist. Or they have a psychiatrist, but the promotion system is such that the administrator is made the head, but not the profession. Very complicated. Each country you go, there's challenges like that that you have never heard of, or you heard of, but you never seen it to believe what's going on. So the enlightened leadership for change, not many. The people at the top say, no, I think we need to change this. I think we need an expert. I think we need to call somebody who can help us, and so on. Support from NGOs. In many countries, there's no NGOs. So that's one problem. But support from NGOs where they're available, able to work more freely, gives that chance for change. But of course, they cannot go into a hospital and control everything. They can create awareness, change the minds of the public, and so on. But as long as the practice of psychiatry in these psychiatric units, it's like what I showed you, donated cells, the public will listen to you. Yeah. I know psychiatry is about mental health and humane treatment and all that, but why is that you need a cell? I mean, they're dangerous. You professionals need a cell to treat that person. So there's something wrong with the way we are propagating change, but not doing it. So the start of non-institutional services, having a daycare or day treatment, having a stress management clinic, can change public attitudes to create a groundswell of change. I have experienced this in several countries. Some of them are not really low-income countries, they're sort of medium to high-income countries. But the attitude change has been very difficult to bring about. To summarize, local passion for change, not transplantation from afar, from a rich country that has got everything, come back and say, look, do what I do. Yeah, I can do it, but where's the money? Where's the staff? We have only one psychiatrist, you have 24 psychiatrists. It's the reality. And then get the professionals involved. Authorization from higher up, very important in low-income countries. They are low-income countries. They will listen to people who are very powerful, world level or regional level bodies who have got power, like the World Health Organization is highly respected in most countries of the world. So you can walk in there with the WHO request that we want to do this, can you help us? And most of the time, people don't have hesitation to accept that kind of offer of change. Heavy powered endorsement is very important, and support if they have money. Money is not everything, but attitude change requires heavy endorsement. Otherwise, you are like one person against the world. You've got some ideas, but nobody supports you because you don't get a heavy endorsement from overseas. Now, I must warn some of you about what I learned from a developing country. I'll tell you, I worked in many developing countries, many low-income countries. When I went there, I asked them, you have got many people from high-income countries coming here to help you. So how come you're still having situations where patients are locked up, grilled, and poorly treated? There's no bed, people sleep on the floor, there's no mattress. How come those people come from countries where everything's available? Haven't they come and taught you what to do? They laughed at me. I said, why are you laughing? They said, these are people who come here. Bring aid, no doubt, but we call them boomerang aid. All of you know what the boomerang is. Boomerang is a wooden curved stick that can be, or sometimes a cross stick that you can throw out. It goes out, knocks an animal or whatever it is, even kills an animal, and then comes back to you. It does the damage and comes back. So you can take it back and use it again. So they say this boomerang aid is, they send people who are theoreticians, mismatched, inapplicable for the aid that they really need. They in fact call them parachute consultants. They're not psychiatrists, pretending to be clinicians. Even they're psychiatrists, but they transplant what they did in their own countries with all the resources and expect that this will work here. That's why it's not worked. So I was very surprised. I thought that they could share some of the experience of those countries. In fact, some of these people in the low and medium income countries have actually worked or been trained there. When they came back, they couldn't implement it. And the people who came from there as consultants also couldn't help to implement it. They're very complex things. It's very simplistic to think that, oh, you didn't get help, you don't have money, nobody came to help you, or the people who came did not know what they. Far more complex than that. So money is not everything. And this is the serene room you see here. It's in a relatively high income country in Asia. And a low income country on the right, you see that with the grills, patients being treated like that. Money is not everything. Attitudes of professionals and passion to change more important. This is the mental hospital in Malaysia in the 1970s. After some training and teaching and showing examples from other countries, 2 years later, they had a big debate. Some of them said, no, we cannot change the hospital because patients are dangerous. Some said, no, we can. They said, you grow trees, they will eat up the flowers. If you grow trees, patients will climb up and hang themselves or jump down. We cannot allow all this. That's a typical mental hospital. 2 years later, I came back and this is the same hospital. So different. Why? They planted trees which could not be climbed, and they planted flowers, bougainvillea, which are full of thorns nobody can eat. So it's a change of attitudes of the staff that made the difference in this change. I went to another country where an unused mental cell, an outhouse in Rarotonga, in Cook Island, had been unused for 10 years. Somebody built it for the mental ward, like a cell with all these grills and barbed wire and gate and everything, which proves that money or buildings do not equate a mental health service. And this change was spearheaded by a mental health nurse who had that passion. Remember I told you about the passion for change? There's no psychiatrist in Cook Island. So she came back from New Zealand and said, look, I want to change. No money. Yeah, no money, yes. So she got some help from the church, got some old pieces of wood, got some volunteers in a carpentry school and built a building. Actually built a building. And before the building was complete, it's already started its stress management, rehabilitation, daycare. And this is a team, the NGO. They invited me to go there because I met them at a WHO meeting and they said, can you come and help us to get things moving? We don't have a psychiatric ward. We have a cell, which we don't use, but there's no service. So Mariana is there on the right, you can see. And these are members of the team. And that's myself. So the local leader with a passion for change is crucial in bringing about that attitude change. And I went as the invited catalyst, non-parachute type. And I had a lot of experience by then. I'd worked for something like 30, 40 years or more as a psychiatrist. And I worked in developing countries, high-income countries, everywhere. So I knew what could be done. Although it was challenging, something could be done. And this is the first workshop we held. They had many workshops after that, run by them. I've been there about 10 times. And each time I go, I help them more, give them material, a lot of material, and show them how to do it. And very enthusiastic supporters. Many of them are not nurses. They are just volunteers. They are prison officers, police officers, and so on, joined in that. Then we got the center started, was working, but they're running short of money. Money is very important. And so I told them how to do it. I said, let's create some craft work and sell it at the tourist market. A lot of cruise liners come to Cook Island. It's a beautiful place, marvelous place. And so they started making some leis, which are garlands made out of shells, not flowers, but shells, and fans made out of palm leaves, and batik, and a lot of craft work. And they sold it at the tourist market. They also sold curry and rice and all sorts of things. And they had even a sort of gambling session, tombola, which they made some money once or twice a month. And they used that money to run the center. They had donated bread from local bakeries. So basically, the money to build the center was less than 3,000 New Zealand dollars. They used New Zealand dollars there, which is less than 3,000 US dollars. It's about 2,000 US dollars. We donated wood. Carpentry school donated time, expertise. And from one building, it changed to 4 buildings. 2 of those buildings were donated by the Japanese government, which saw the excellent work they did. And this is one of the training programs on Mental Health Day in Rarotonga recently. Similarly, but this time with the full support, that was the support of only the NGO. The government didn't give much support in Cook Island. But in Mongolia, I went there in 1998 through the World Health Organization, which gave full endorsement. And of course, the Mongolian government gave full permission for me to go and create a non-hospital based rehabilitation program. So I went there several times and saw the best thing was to make the rehabilitation program outside of the hospital and based on the local industry, the local people's way of living, not transplant some idea of setting up a rehabilitation factory or something. So we got the first GER, or the tented houses, and since then we got about 20 donated and given by WHO and so on. And the first one was opened in 1999. And that's myself there with the hospital director, and that's on the extreme right is my wife, who also comes with me on many of these benches. And we got involved in so many things in herding of animals, which is the main occupation there, craft work, farming, all sorts of things. And in 2008, when I last visited them, they had 8 GERs like this next to the hospital, where patients were more free doing their activities, so on and so forth, and brought about a paradigm shift in the care of the mental patients. In Fiji, I was called by the Ministry of Health in 2011 to set up 3 psychiatric units outside the only mental hospital for the first time in 125 years. And again, the money was mostly donated, hospital slightly modified. And we opened the first stress, we changed the name. That's very important. We need a paradigm shift. So we don't call it psychiatric ward, mental health ward, and all that. Call it stress management ward. And this is the Dr. Kiran, who's the medical officer then. Now he's a psychiatrist. And that's myself there, cutting the ribbon to open bring about that change. This is my own country in Malaysia. I worked this the longest period in Malaysia, but some years overseas in other countries. And in the primary care center that my university uses for its teaching, thousands of patients, as I mentioned, about 1,600 patients every day. Saturdays, Sundays, maybe down to about 800 on Saturdays. Sundays, I think there's no clinic, but they have on call. And we had a small room they gave us, which is not enough because it's shared by everybody. So what we did was, after some effort, I said, look, I can donate about $1,800 worth of a cabin, one of these porter cabins. And the clinic was so nice, they gave us a roof because it gets very hot in the Malaysian tropical climate. They gave us a roof. The air conditioner was supplied by me, and the electricity was supplied by them. And we got a stress management clinic going for teaching students about anxiety and depression and stress. Psychosis, occasionally we'll get, but we will treat as best as we can and refer to them for the more long-term management at the psychiatric clinic about 4 kilometers away. So this was mainly for primary care patients who are under stress. There are at least 300 of them every day. We cannot obviously see all of them. So we would select about 2 or 3 patients, mainly as a teaching clinic. And we have offered this for the nurses who we hope they can join us. Definitely not teaching like we did in the low-income countries through a grilled bars of a cell. So that's my last slide. If they can do this change, why can't you? Thank you very much. Thank you.